Thank you, folks. I'm Keith Smith. I'm Senior Vice President for the Leavitt School of Health at Western Governors University. It's my privilege to be the moderator for today's panel. So let me introduce you to our panelists. First, to my left, Beth O'Connor. She has an MED and has lived in rural areas almost her entire life. Her University of Cincinnati master's degree was the only 2 years in a major city. Now that's an accomplishment. She has been the executive director of the Virginia Rural Health Association since 2005 and was the National Rural Health Association president in 2022. She's a contributing author to the recently released Mass, Misinformation, and Making Do, a compilation of firsthand pandemic experiences of rural healthcare providers. Next, on the far left is Dr. Alex Ding, the Associate Vice President for Physician Strategy and Medical Affairs at Humana. In this role, Alex focuses on driving enterprise-wide physician and provider engagement and advocacy, cultivating relationships and collaboration in the wider medical community, and advancing a clinically focused corporate culture to drive member and patient health and health outcomes. He remains a practicing physician and is on faculty at the University of Louisville School of Medicine. He has previously held other academic posts at Harvard, UCSF, and Stanford Medical Schools. Alex served as chair of the American Medical Association's Council on Science and Public Health during the height of the COVID pandemic, and held a gubernatorial appointment on California's Health Professions Education Foundation, seeking to expand the healthcare workforce to underserved and rural areas. And last, in the middle, my colleague, Dr. Janelle Sokolowich, serves as Academic Vice President and Dean for the Leavitt School of Health at Western Governors University, providing leadership to undergraduate, graduate nursing, and health profession programs. She's been an academic leader for well over a decade, having held various roles, including Dean of Academic Operations, Interim Dean, and faculty. Her passion for student success is marked by her drive for innovation to reach all who desire a degree. Her passion for rural health was heightened during the pandemic and now has become her mission in creating pathways for the underserved, specifically those in rural communities. It's a pleasure to be able to moderate this. I happen to be a small-town boy from a rural area in Northwest Washington, so this is near and dear to my heart. Let's start with this. As we know, rural health is facing multiple, complex, critical challenges. From your vantage point, what do we need to do to prioritize things to turn this around? Let's start with Alex.
Sure, thank you so much. And I agree, it's definitely a complex issue. Certainly is no single magic bullet that is going to be the panacea. And I would say, for me, that there are three top priorities. One is supporting rural healthcare providers in the workforce. Two is expanding access to care by building capacity. And three is tailoring financial incentives to drive transformation in the rural healthcare system. Let me talk a little bit more about that last one. What I mean by that is accelerating innovative financing models, things like value-based care or accountable care. And what that is a fundamentally different business model that transforms the healthcare delivery model from the traditional fee-for-service model. So the traditional fee-for-service model really focuses on volume. Providers get paid to do medical stuff to you or for you when you're sick. Accountable and value-based care instead focuses on quality and value, which is trying to keep you healthy and engaging you in your health rather than only engaging you when you're sick. And so our data and our experience has shown that there's better health outcomes, lower costs, and overall better satisfaction with this sort of practice. And so we've also seen that there's more investment in wraparound services like mental health and social support services, that there's higher rates of innovation like the use of telemedicine, which is of particular interest in rural communities. And what we've seen is that there's just more stability in the financial payments that come with this sort of system. This is something we saw during the COVID pandemic when there were the acute shutdowns. The value-based care clinics were able to stay afloat financially and were in much better shape, so they were able to provide better access to care during those difficult times.
Thank you, Alex. Beth, from your perspective?
Sure. One of the things we see in our rural communities is we need payment systems that work. Our rural communities have a higher percentage of patients on Medicaid and Medicare, more farmers and other self-employed people who don't have traditional service, and our rural hospitals have 10, sometimes 15% of their patients don't have any insurance at all, any way to pay the bill. And so you can imagine, what would happen to an apartment complex or a grocery store if 15% of their customers didn't pay for the services. Because hospitals have a federal mandate to see anybody that walks through the emergency room door. So we need rural payment models that make sense in rural communities.
Thanks. And Janelle, from a nursing and educational standpoint.
Yeah, so that's what I was going to say. You took my line. As a nurse and an educator, I think the number one opportunity for us for rural health and the most impactful is lack of access to education to build a workforce. So there's two kind of, pivotal things you must have: a workforce and access to health care. We did a study recently looking at rural communities across the United States, since we serve all 50 states in our school, thinking about this strategy. And in Missouri, we looked in depth, and we recognized that there were areas within Missouri that had greater than 100 miles before there were any mental health services. So you have a primary care physician or a family nurse practitioner medicating some with severe mental illness, schizophrenia, bipolar disorder. And so what do? You need to educate your community where they are so that they can become the workforce. So I see those as kind of the two pivotal areas that we need movement on to really make a difference in the rural community.
Thank you, Janelle. Rural Americans are more likely to face health and care challenges as compared to urban Americans, including such issues as heart disease, stroke, cancer, unintentional injury, and chronic lung disease. What are the leverage points we have to address these disparities between rural and urban population? Alex, you want to take this first?
Yeah, and I would say that the focus on health equity at this point in time, I'm really heartened to see that we are spending more time and focus on this. And I think one thing I don't want to lose, especially as part of this conversation, is the divide that exists between rural and urban populations. I think, I want to make sure that that is not forgotten and that it's addressed in the same breath as when we talk about disparities that exist with racial differences and socioeconomic differences, because these are just as important, and I want to make sure that it's something that we continue to focus on. The three things I mentioned earlier, kind of the foundational items, I still think are part of the leverage points to be addressed here. So shoring up the health provider workforce, expanding access to care, and incentivizing different payment models that focus more on whole person care and keeping people healthy. That having been said, I would say for this issue, I would say there's maybe three additional ones I would add to that. One is an investment in data and analytics. And I think you don't know if it's happening, you don't know what the impact is, you don't know how you are affecting it unless you're able to track it and trend it and see what's happening. So one is investing in data analytics. Another is baking in those incentives for addressing health equity. So, I've alluded to these new payment models that pay for value to keep people healthier. And what we're trying to do is we're explicitly trying to reward healthcare providers for managing panels of patients, for managing populations. I think part of that includes closing these gaps that exist in health disparities and being rewarded for that financially as well. And then thirdly, I would say really community engagement and partnership is really important. I think so much of a person's health is dependent on social interactions and being part of a wider, greater community. And I think that is particularly true in rural communities. And so I think healthcare systems need to partner more deeply with those community organizations that are out there, not just the nonprofits that are in healthcare or social services, but I'm talking about organizations that are really the true bedrocks of a community, like churches, for example. Mm-hmm. Just as an example, something we did at Humana is we partnered with a number of clergy and churches in the South when COVID vaccines were being rolled out. And we found that by partnering with these organizations, we were really able to improve the vaccine uptake in communities that had a historical low trust of the healthcare system. And we found that in those communities there were higher disparities related to COVID illness, and by engaging in those sorts of partnerships, we were able to close or at least narrow some of those gaps.
Really helpful, Alex. Thank you. Beth, you live and work this every day. Your thoughts?
Yeah, I think what people need to understand is that in rural communities, the economy is based off of what can be extracted from that community. Coal, timber, cotton, produce, livestock. And so what happens is, first of all, those jobs are inherently more dangerous than jobs in urban communities and are less likely to have health insurance. So you see the disparities in health outcomes. But what compounds that is the income generated, the profit generated from those economies doesn't then come back to the local community. Coal, timber, big ag is owned by people in urban communities who pay taxes in urban communities who don't have any sort of vested interest in that local economy. So for rural areas to really move forward, they need to find economic drivers that can have a direct impact in that community.
Well, that's really helpful. Thank you. Beyond genetic propensities and environmental issues, much of a person's health status is impacted by lifestyle and social emotional drivers. Alex mentioned this a moment ago. What is the role of education and healthcare in addressing these non-direct treatment needs? Let's start with Janelle.
Yeah, I think the first is really educating on payment models. We do a lot in healthcare education. We think about direct patient care as kind of being the first part of education, but we have fast forwarded past that. The pandemic taught us a lot, specifically relevant to value-based care. So integrating understanding of value-based care within education systems. Also, integrating health and wellness within our current infrastructure. We have to actually begin to teach practitioners and undergraduate health professionals these health and wellness behaviors within our curriculum. It's not integrated in how to take care of yourself and how to use yoga and our thinking positively, just basic understanding mental health and awareness of mental health illnesses and what the predicates are for you to have a mental illness. What are the risk factors for mental illness? How do you care for yourself if you have a family history of mental illness? And then moving into patient care and delivery of a population. Traditionally, our health education has been very centered on a single person, a single disorder, or multiple disorders in a single person. But we really have learned through the pandemic and prior to, with the impacts of social determinants of health, that it really is about a population at large. And that's what I see when we think about a rural healthcare system. We're thinking about a population. How do we impact a population? How do we teach within our health education? We have not historically taught how to manage a rural population of people and providers. We don't talk about a mining injury. Okay, that's not part of our infrastructure or our technology in our books. It doesn't speak about the specific determinants that you have within a population. We're talking about 40 million people, you all, in rural communities. That's 40 million, not 4,000, 40 million. And so we are missing that education, the same as we recognize when it came to intergender differences. We didn't have it integrated within our curriculum. And so we had this entire population of people that we weren't prepared to care for. It's very similar to rural healthcare where we are missing the mark. And so that's what we're trying to do. We're trying to transition and integrating it within our health education, undergraduate science education, so that people are prepared to care for an entire population of people.
That makes sense. Beth?
Yeah, I would agree with all that, but I think we need to start sooner. I would like to see high quality health education K through 12. Somebody's going to be offended that this comes out of my mouth, but I see far too many, both rural and urban, health teachers in K-12 that are an unmotivated athletic coach.
Alex.
I don't know if I could follow that. But I think the discussion about social drivers of health is a really important one, and that's kind of where I want to take my response. I think a lot of people don't realize this, but 90% of what we spend on healthcare is on medical services, but that healthcare itself actually really determines only about maybe 20% or so of a person's overall health. And so what we're actually spending on for medical services are really addressing the downstream effects of multiple complex social factors that go into determining a person's health. And we want to move a little bit upstream. We know that so much of a person's health depends on things outside of the healthcare system. Structural drivers like public policies, labor employment policies, cultural issues and values, social drivers like income, educational attainment, living conditions, health system access. And I'm not suggesting that those of us in healthcare try and address all of these things. What I'm instead suggesting is that when we're looking to try to improve health in a population, that we shouldn't just be looking at the health system, but we should look at really the totality and the sum of that society or that community. And I think that there certainly are some unique drivers in those rural communities. But I am heartened to see that more and more healthcare systems are beginning to adopt the whole person sort of care model. And I think those of us in healthcare can move a little bit upstream and look at health adjacent social needs that we can try to support. So these would be things like food insecurity or transportation issues. And for us as an insurance company, we've invested in the data and an analytics infrastructure to create these predictive models to figure out who might be at risk for some of these things. We then feed some of those things back to the providers and the healthcare professionals in those communities so that they know, one, and then two, so that they can try and help address them with their patients when they see them. And of course, we're not just giving them information, we also want to make sure that they've got the resources that they need to help address some of those challenges, and also provide some payment and coverage solutions to help address those. For example, paying to make sure that you can get a ride to your doctor's visits, for example, or getting healthy food cards such that when you go to Walmart, for example, you can use them to buy healthy groceries.
We'll hit on some really practical aspects. I have to land on Beth's response a moment ago, because way back when, one would think things have gotten better by now, but back in the day when I was in high school, one of our health education teachers was my high school football coach, whose solution to everything was put an e-brace on and suck it up. So hopefully we've gotten further than that. So one of the most pressing current challenges is in healthcare, sustaining a well-trained, adequate workforce. COVID dramatically challenged and exacerbated that workforce shortage. What solutions and investments are needed to ensure appropriate levels of staffing to provide quality care in rural settings? Beth, let's start with you.
Two basic things. Treat people with respect and pay them appropriately. During the height of the pandemic, we saw nurses who were forced to work overtime, caring for a number of patients per shift, which was completely unrealistic, and having to endure both verbal and physical abuse from those patients. No surprise, some of those nurses chose to not be nurses anymore. And some of those nurses left the traditional hospital and clinic environment to be travel nurses, where they got more say over how much money that they made and their work environment. Those nurses were called greedy and selfish for wanting to pay the mortgage and have a safe and work environment. Pay people appropriately, treat them with respect.
Alex.
Yeah, I think the way in which I think about this is kind of in two big buckets. One are the people who are coming into, or we want to come into the healthcare workforce, and the other are the people that are already existing in the workforce. So I would say with regard to that pipeline, I think that medical training is so often concentrated in large urban areas and large academic medical centers. I really think we need to bring some of those training programs closer to the community level. And I think we really need to invest those training programs, particularly on primary care. And I think by bringing those training programs closer to home, you're more likely going to get someone who's from that community, who understands what those unique challenges are in those communities, people that are already known entities and trusted. We know trust is such an important part of that therapeutic relationship. And we also know through research that people are more likely to stay and practice in the community in which they trained. And so I think that's one part of it. The other part of it is really, unfortunately at this point I would consider more urgent, which is the supporting and sustaining of the current workforce, because burnout really is at an epidemic rate. So in the last year, we did a joint report with the Medical Group Management Association that showed that 2/3 of physicians in this country were experiencing burnout, that is, feeling overwhelmed and emotionally drained. And I have no doubt that that is more far-reaching to basically all clinicians out there in the workforce. And so I think not only should we be concerned about this because of capacity issues, particularly in rural communities, but we also know the evidence shows that burned out clinicians have detrimental effects on the quality of care and health outcomes. And so I think there are a lot of different ways in which we can talk about thinking for mitigating burnout, but I think one of those solutions is not about just building more resilience in the worker and in the individual. I think it's really the challenge of working in a system that isn't supporting these healthcare professionals to do what they think is right for their patient. And I think the healthcare systems really need to look at how they're supporting their healthcare professionals to do their best work, to really best take care of their patients, because that's what they got into this line of work for. And I think, we talked about these new innovative payment models, and I do think that these can be an additional positive driver to professional satisfaction, because it does give them that opportunity to step off that proverbial hamster wheel, so you're not just churning through patients every 15 minutes to make ends meet, but rather you can spend more time with patients, you can build closer relationships, you can have closer connections and ties, you can better understand that whole person, and as a result, you get better outcomes, you take better care of patients, and you have a better time at work doing it.
Yeah, thank you. Janelle?
Yeah, so I'm going to talk first from a nurse perspective, right? I've been where I felt close to burnout before. I'm a pediatric nurse by trade, and I went through the first, prior to this last year's RSV season. I was in the middle of it, and I went to the morgue 9 times in 6 days, and with babies. And it was a turning point for me in my career. I was actually in the middle of a nurse practitioner program and transitioned to education because I could not imagine myself doing that for the rest of my life, and I didn't have kids at the time. So I think there comes this sense of we have to use innovation in every aspect of the word. So when we think about a current nursing staff, be really innovative about thinking about how you're using your staffing. What do their hours look like? What do their days look like? And unfortunately in nursing, we eat our young. We are not kind to the new nurse who is novice. We have not created the partnerships that existed in the past. So we really need to create an ability for people to buddy with other professionals, other nurses, even across organizations. So that they have a partner, a place to rest their head, to really talk about the challenges in being a practicing nurse at the bedside. Secondly, we need to hold nurses accountable that are mean and hateful and spiteful to their colleagues. They need to be held accountable, and we need to think about their schedules. For my first 5 years, I had to rotate. So I worked days and nights in the same week. That is not livable. That is not valuable of me as a person. I would work Monday, Tuesday day, Thursday, Friday night shift for many, many years. And that was expected of me. It was my rite of passage to go through that. And I think we have to rethink that. We have an aging population. Average nurse is in their 50s. Over 50% of nurses will leave the field in the next 3 years. So we have a massive shortage. Now, from an education perspective, we talk a lot at WGU about upskilling and reskilling. And one of the things we have to do is upskill. And that upskilling is not traditionally where you would think it. We're talking about the environmental service worker, the person who worked in the cafeteria for 10 years. They're phenomenal with patient care. We need to be able to upskill them in the rural communities because they're actually there and they're invested. They have a family, they have a legacy. Now, the 18-year-old, phenomenal. go ahead and introduce them to healthcare. Hope that they stay. More than likely, they're going to want to leave and then maybe make their way back home at some point. But really think about your current staffing. The lady at Dollar General who's working at the checkout, she's committed. She can be educated. And so institutions like ours, we have the ability to impact those spaces at scale without the impact of costs, and allowing them to do it from home and allowing them to do it on their own time. And that makes a significant difference. But I need partners because we can't do this alone. We have a shortage. We no longer are in competition in health education. So we can just let that go. There's no more competition. We have a massive shortage. So we need more partners who are willing to do it. And then we need innovative ideas. So I recently learned about a young lady, her name is Dr. Schneider, and she started a company called Homeward, and they actually have a mobile clinic that has full capability, and they bring it to the middle of nowhere. And so we need to start thinking innovatively. Providence Health System is piloting right now a virtual nurse. So they have one in-person nurse to 30 patients, and every single patient has a virtual nurse. A nurse that is just retired, who is phenomenal at her job, who's there virtually with a computer, and they can zoom in on anything. They can do the admission and discharge, a lot of the administrivia that we do as a nurse. They can do that so that the nurse can actually provide care. There is a way that we can get truly innovative in how we're doing our work and bringing it forward, but we need partners to do it. We need significant partnerships that we've never done before, partnerships with large companies, partnerships with organizations, so that we can actually impact at scale. There's a Dollar General in every single rural community. There's a Dollar General, and there's also a dialysis center. We need to think about that, right? They were willing to do that. Why are they doing it? They wouldn't do it if it wasn't a good business decision, because they know that there's a need there. And so we can start upskilling from within those organizations and communities and providing education at scale. We need to remove the barriers on getting access to scholarships and grants so people can complete their degrees. There's an opportunity here, but there's an entire population of people that are depending on it. When a hospital closes, and Beth can speak to this probably much better than myself, but when a rural hospital closes, you're talking about generations of people who become unemployed. You change a whole infrastructure of a community. We can't have that happen. We had over 100 hospitals close during the middle of COVID. Close in the middle of a pandemic. That happened, for real. Can you imagine that you have COVID and you have to drive 200 miles? That's almost unbelievable. The morbidity and mortality rate of maternity patients in a rural community are that of a third world country, and they're here. So there's a time right now that we have to get really innovative, really inclusive, thinking about the community at large and the impact that we can make in health education.
Thank you, Janelle. These challenges are huge, aren't they? In my home state of Washington, I just read an article that in a very rural area of my state, the lone obstetrics clinic closed. And now people will have to go 45, 60 minutes to the next nearest one, hopefully in not dire weather conditions. So these things are very, very real. Given the challenges of the funding mechanisms that currently drive the economic model for rural healthcare systems, what alternative or innovative payment models would support a more sustainable healthcare system? Alex?
Yeah, I've already alluded to this shift in financing models from fee-for-service medicine to value-based care. And again, I've alluded to what it is shifting from incentivizing for volume to paying for value and quality. And so I think it addresses so many of the challenges of rural health systems, and quite frankly, of the overall U.S. Healthcare system as a whole, which spends more per capita than anywhere else on earth, and yet at the same time doesn't achieve that great of health outcomes. And so we really aren't getting what we're paying for. And so it's something that we at Humana are heavily leaning into, as is CMS, the Centers for Medicaid and Medicare Services. So it's something that we've got a lot of data on, and we publish a report every year called our annual value-based care report, which is going on 9 years now. But we have shown in our data that these value-based care sorts of models, the care that people receive from their primary care docs, on average, you get better health outcomes at a lower cost. People have more preventative care, they get more access, they have more touch points with their primary care providers. There are more options for innovative types of care models such as telemedicine or at-home types of medical services, and increased patient satisfaction as well. All at the same time, it also saves the system overall money as well. That means less out-of-pocket costs for patients. It also means that can lower their insurance premiums, and more investment can be made back into the actual benefits of their insurance coverage. The physicians that practice in value-based care settings also see a benefit with this sort of practice. We've seen that on the whole, they end up receiving more of the healthcare dollar as primary care docs. They earn more than twice the healthcare dollar compared with a non-value-based care physician, and compared with the Medicare fee schedule, it's in upwards of 5 times more. And that's all, I'm saying that not to say that, those doctors that are in the rural communities are going to be, doing much better and enriching themselves. What I'm saying is that really allows them to have a lot more financial stability in their practices. And that is really in dire need at this point in rural practices and rural health systems. And I think allows them to really invest in the healthcare delivery system at a time when it's incredibly needed.
Thanks, Alec. Beth, what would you add in there?
Yeah, the current payment model is what we refer to as heads in beds. If there's not a patient in the hospital, that hospital doesn't get paid. And so from a very cynical point of view, it doesn't pay for a hospital to keep people healthy. So what we need are reimbursement systems that gives community members the incentives and the tools and resources to take charge of their own health. Programs such as chronic care management, where a hospital or clinic has a nurse to check in on high-risk patients daily if need be. Programs such as community health workers, where there are lay people in micro-communities, such as an individual neighborhood, who serves as the trusted public health voice in that neighborhood and is a resource for things like, when we have a COVID vaccine that nobody knows what this new vaccine is and is it safe and blah, 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 that person is the person that they go to.
Yeah, makes sense. With increased movement towards value-based care, what strategies do you suggest for higher education and health leaders to better prepare future healthcare practitioners to understand and support its advent within healthcare? What have been some big barriers to this transition from your vantage point? Beth, again?
I don't think you have to explain value-based care to healthcare providers. Most people go into healthcare careers because they care about people and want to help them. And especially in rural communities, a patient in a rural clinic isn't a number on a chart. The patient in exam room 3 might be your neighbor or your aunt or your Sunday school teacher, or let's face it, in a rural community, that person might be your neighbor who is also your aunt, who is also your Sunday school teacher. We see consistently that healthcare outcomes, healthcare quality in rural hospitals is higher than the big urban facilities, partially because people know their patients. They know that maybe they don't have a safe source of water at home. They know that they have a hard time getting transportation to work. They know these things about their patients and can help accommodate those. So I don't think you have to explain the value of value-based care. I think what's broken is the payment system. Until value-based care compensates hospitals and clinics to give them the funds they need to maintain their facilities and appropriately pay their staff, it's going to be hard to adopt.
Yeah. Janelle?
From an education perspective, it's really about us understanding preventative medicine. We still have a ways to go in really moving toward helping K through 12 students as well as undergraduate students in higher education understand what preventative medicine is and how to really move their patients toward wellness and understanding the impacts. From a nursing perspective, I believe it's policy and advocacy. I was just telling them at lunch, it just came out, it was a comment in a paper that talked about how 90% of hospital boards do not have a nurse on the board. How is that possible when we're the largest employee of a healthcare system? We are the major people they employ, yet we don't have a voice on the board. So you're making decisions about a healthcare organization, about how value-based care can impact patient outcomes, and there's no voice there for that. Because we would be the #1 advocate for value-based care. Why? Because we care about the continuity of care and actually seeing patient wellness. We don't get incentivized for our patient not doing well and continuing to come back. We, again, have to take care of the patient who we just discharged, spent all of that time educating, and the next week they're back for a bed sore because we were understaffed, and therefore we couldn't turn the patient. We would see significant differences if we were advocates more as a profession. In education, we really need to move our students toward understanding what preventative medicine is and helping patients understand how they can control their own health and taking control of their health. We have to build empowerment within our students. I will tell you, as a novice nurse, I wasn't confident in my understanding of how to help a person actually be well and not return. I knew how to fix the disease once they were in front of me, but really educating them took time, many, many years of seeing some of the challenges. I remember never understanding why I had to do this admission database that was about 40 pages long, because I started as a nurse before we used computers, 40 pages long asking them all these questions. But I'll tell you just a really quick story. So I was working a night shift and I was super bored. I'm an ICU nurse, so most of my patients are asleep. And so I was working the night shift. I was so bored. It was 3 a.m. I didn't have anything else to watch. There was nothing on TV. At pediatric hospitals, there's nothing on TV. So, and you never want to have anything on the TV because even though they're sedated, they can hear. So, you can't just watch anything. So I decided I'm going to go ahead and do the admission database. Nobody wanted to do it anyway. It's pages and pages long. And I finally get to page 4. And it asks about mold and food insecurity and if anyone's abusing you at home. And I get to the question about mold, and she says no. And I ask her another question about her home. I can't remember the exact question. And she says, well, the complex comes every couple weeks and wipes down my walls. I said, what do they do? She said, yeah, they wipe them down. Well, her daughter was 2 and had been intubated 7 times on a ventilator, 7 times. Perfectly normal birth, nothing wrong with her. We did not know why. She kept going into respiratory failure. Didn't have a reason, just kept coming back to the hospital, kept coming back. And I get to that question that probably she'd been asked 1,000,000 times, but the person skimmed over it and just checked no, right? They looked at her, she looked put together, she was always there with her child, and probably rushed through it, I'm guessing. But I finally decided to ask all of the 111 questions. And I got to that question, and she said, we wiped down the walls. What do you mean? Come to find out, they had black mold in their apartment. So I spent the rest of the night identifying who the owner of this complex was, and I called. And the next morning, I talked to a social worker, and they had been removed. You think about education. I had not been taught how important that admission database was. I didn't get a story about how this 40 pages was so important to the care of a patient. So it does start with education and building this understanding of the impact that we can make for preventative medicine. And so I think there's some opportunity for us as both a nurse and an educator to really build the support that we need to educate the future learners that as they're coming through and the impact they can make on the health and wellness of an entire population.
Thanks. Alex, briefly?
Yeah, I do think practicing in a value-based care sort of practice is somewhat different. And so I think the educational component of it is really critical to enabling the success and the growth of value-based care. In my own experience, in my own medical training, and also now as a medical educator myself with my residents, how we're training them to practice is really in a traditional fee-for-service type of model. there's not really a curriculum on how you practice in value-based care. I think it's one that certainly needs to be further developed and formalized. And I do think value-based care in many respects is a different sort of practice. We still use the same biomedical paradigm for traditional medicine, but I think it's more expanded to think more about the whole person. And so it's really more of a biomedical psychosocial type of model. And it's something that, I was starting to hear about and being taught when I was in medical school so many years ago, but that was kind of at the theoretical sort of education. But only now are we seeing what does it mean in practice? How do you actually operationalize it? And I think in many respects, a lot of practitioners still don't know what that means in day-to-day practice. And so, one of the challenges we have in growing our value-based care clinics, center-wide primary care clinics, are finding enough clinicians who know how to practice in these types of settings. And I think physicians and really all clinicians know that this is the right thing to do and this is why they got into healthcare, but they don't necessarily know kind of the nuts and bolts of how you actually do it on a day-to-day basis. And so, there's some training that we can do on the job, but I really think that there's more partnership we can develop with residency programs to be able to develop training to practice in these models, because I do think that there are somewhat different skill sets that you need. Value-based care is fundamentally more team-based, for example, so we've got to train our practitioners to learn how to better lead teams. There's a lot of working with patients through lifestyle modifications to address some of their chronic diseases. And so how do you teach them to do better motivational interviewing and behavioral change? And then a lot of it is about kind of managing populations in addition to just the individual. And so that means a lot of data and analytics that you need to put in place in those practices. And teaching how do you interpret that? How do you make sure that you've got the right infrastructure in place such that you're able to manage the entirety of your patient panel and population in addition to the individual patient in front of you?
Thank you. We're going to open it up to the audience in just a second, but a real brief response. How do we enable rural students to consider healthcare careers and be able to enter health programs without leaving their locales? Janelle, then Beth, very briefly, please.
Yeah, I think at the end of the day, they have to see the pathway. They have to see the difference that it makes. We all know that you change a generation through education. Your generational wealth, your opportunity, the social determinants of health are all directly impacted by your education and ability to reach that pathway. They have to see what the end game is. They have to see a person who looks like them, successful, who came from their same background. So we have to build that future pipeline, and we have to let them see what they actually can become with an education.
Great. Beth?
Broadband. Too many people in rural communities still don't have access to broadband, self-included. Two, I would like to see a greater investment in middle school and high school guidance counselors. When you ask a fifth grader about healthcare careers, they know of two options, doctor, nurse. It's binary. They don't see the full spectrum of possibilities for healthcare. And so we need guidance counselors with the knowledge to understand which students, which personalities, which skills fit into which types of healthcare professions, and they need the capacity to mentor students along those lines.
That's great. So we do have a few minutes for questions from the audience. A little hard to see you out there, but we'll get you.
Kind of see.
Yeah, I'm really curious about, so my sister just finished at BU School of Medicine. Oh, thank you. My sister just finished at BU School of Medicine to be a PA, and she's in the process of applying to programs, to jobs all over the place, but primarily in Boston. She got her start in Boston Medical Center in the ICU, and she was really focused on sort of like city medicine and sort of the issues that are faced racially along like racial lines in healthcare. But part of the conversation after she graduated was the process of like looking for jobs for other marginalized communities. And she did consider moving into a rural area because one of the issues too on top of being in medical school are the huge amount of debt people enter by entering medical school. And so I'm wondering sort of from your perspective, what are some solutions, whether it's policy, that are beyond the medical field, that go into like higher education, that could potentially help hit the mark on attracting more people who are coming from these huge programs in cities to actually be able to leave those cities and then potentially get like tuition reimbursement, or like I forgot what the word is, but where it gets eradicated after like 30 years of working for underserved communities specifically. I'm curious to know what your thoughts are about that, because I know that there's a pressing issue for healthcare workers in these areas, and we can barely get them in cities as well too.
Oh, absolutely. So my first direction for her would be to check out the National Health Service Corps. They have a number of programs that can help healthcare professionals pay off their student loans or have their student loans forgiven. Many states have area health education centers which can help place students in programs and help pay off their student loans. So there's a variety of programs. My concern is if your sister, for example, comes to Southwest Virginia, works for the ballot health system for 5 years, gets her student loan prepaid, then what? Is she going to stay in that rural community, or is she going to become part of the revolving door? And that revolving door has very much eroded trust in the healthcare system. So there are programs out there. I would rather see programs that incentivize rural students to go to healthcare professionals and then come back home to their rural communities.
Yeah, that's great. Other questions? Back in the back there?
All right, I'll get to him.
Hi, you mentioned community health workers, and I was wondering, it seems like this is an area that is not as fully appreciated and developed, and I'm wondering what the community health worker programs are like. Are they being utilized in all healthcare facilities? Are they, just how widespread are they being used?
I don't know. You can answer that. I don't know about community.
I can do this one.
Okay, thanks.
So, yeah, so community health workers, and depending on where you are, they may be called promotores, other names. Is everyone using them? No. Partially because sometimes it's hard for big hospital systems to wrap their head around the fact that somebody with no degree whatsoever might be a good voice for public health and might be able to help with value-based care. But the other issue is reimbursement. In Virginia, there's no insurance button that pays for community health workers. So the programs that have them, which are using them, which love them, unless they have grant funding to pay for them, don't have a way to keep them employed.
Now, I would just add that we've seen these community health workers work really well in other countries that have made much deeper investments into these programs. And I think it's a perfect opportunity to upskill someone, just as you mentioned, Janelle. And we've seen that, data from those places that do this well have better outcomes because these are people that come from those communities. And so we've alluded to this in many of our responses about the importance of trust. That trusting that healthcare professional in front of you. And if you've got that bond, if you've got that connection, and that certainly is something that I think community health workers can really bring to the table. But I agree, it's something that in this country is still underdeveloped, underinvested in, something I would love to see wider deployment of.
I'll just tell you, this is, kind of a mix of these two questions. One of the things that I have personally feel that I need to be an advocate for are wraparound services. As a person of color, I will tell you, in my family and where I grew up, it's very common that a person doesn't have credit. Their credit's already bad, their cousin used their credit or used their name one time. And one of the things I always see, the government will offer a repayment program or a loan repayment program. Well, you have to get a loan. You can't get a loan, okay? If you think that the person that's working at the Dollar General is less intelligent or has less ability to be successful in college, no, they do. It's the wraparound services. It's how do you get started? So they don't see any way to participate even in community health if they're not being paid a livable wage. So how do they get started? We need wraparound services. One of the challenges we have in the nursing profession, and one of the reasons we have a nursing shortage, is of our own doing, because there's a graduate medical education credit that cannot be used for all nurses in all healthcare systems. It can be used at teaching facilities. If you teach in a large teaching facility, you can qualify for it. Physicians qualify for it. That's why they don't have a problem getting placement, because the government pays these institutions back for taking in physicians. Well, they don't get paid back for taking in nurses. So there are some policy and advocacy things that we need to do at a very large scale to advocate for not just repayment programs, but getting started programs. I'm gonna pay you to drive to clinical. I'm gonna give you gas money. I'm gonna help you build your credit so you could actually one day get a loan. There are opportunities that are needed from those that are underserved and marginalized that just haven't been done, because we need to advocate these nationally. We have to push to advocate for this. Everybody's voice in here counts. And really, all of you all will intersect with the healthcare system. It's amazing to me when we don't have large audiences, because this is the one thing that affects every single person in this building. Everyone will intersect with healthcare. So all of us, it's all of our responsibility, because we all need it.
Thank you so much for joining us today. This is a huge problem. There are fellow Americans out there who deserve that quality, accessible health care, and we are the solution. So thank you for being here. Spread that word. Have a good afternoon.
Thank you.